So I will leave it to Dr. Regales. Thank you very much for speaking to me.
Okay. I guess you can hear me? Yes, okay, good. So I thank you so much for having me today. It's going to be my pleasure to talk to you about new-onset diabetes after transplantation. It's just diabetes in general is a big part of what I do. So I have to say that in my training years, I did deal a lot with immediate post-transplant hyperglycemias in terms of consultations in the hospital. So it's been very interesting to see the post-period as well now in the clinics, following these patients closely. So let me tell you a little bit about it. As you may know, new-onset diabetes after transplant is associated with a lot of morbidity and mortality for our patients. Higher rates of cardiovascular disease, higher rates of infection, and we also see increased rates of graft rejection. And what that entails is that you lose the graft quicker than you would have otherwise likely, and also the fact that you will lose your graft. It's just two big reasons why we need to address this. Now, part of the presentation is going to include defining what new-onset diabetes is, its incidence, identifying its risk factors, as well as discussing some issues with management, particularly in terms of the immunosuppressants and what we can do to treat it once it's present. So before 2003, there was no actual formal definition, and many studies that were done before that date had incidences of the new-onset diabetes ranging from 7% to 47% in the post-transplant period. So it was very wide. So finally, in 2003, a consensus was reached to use the American Diabetes Association guidelines for the diagnosis of diabetes. So at any time a patient meets this criteria post-transplant, you basically have a diagnosis of new-onset diabetes. Just to remind you of what those ADA guidelines are, if the patient has symptoms of diabetes, polydipsia, polyuria, polyphagia, random glucose greater than 200, you got your definition right there, 2 fasting sugars greater than 126, and a 2-hour plasma glucose after a 75-gram oral glucose tolerance test greater than 200. In the post-transplant period, particularly in the first 3 months, you cannot use the A1C reliably since the high sugars have not been able to alter the A1C result yet. So in that immediate post-transplant period, your A1C is likely to be normal. So for the general American Diabetes Association guidelines in most patients, you can use the A1C to diagnose diabetes if it's greater than 6.5, but that doesn't apply to this population. And just to remind you, pre-diabetes is considered a fasting sugar. So this is what we would call impaired fasting blood sugar of 100 to 125, and a 2-hour between 140 and 199. And this is going to become more significant when we talk about risk factors for new-onset diabetes after transplant. To define the incidence of this condition, we need to put it into context of how far from the transplant the patient is, what organ was transplanted, the population that we're addressing, as well as what immunosuppressive agents were used. So it's not as easy as just saying there's a certain one number. It depends. Before the definition, I said like 7 to 46%. Now we know that about 1/3 of patients are at risk of getting new-onset diabetes by 6 months post-kidney transplant at least. And the time from transplant, that factor comes into play more so in those patients who get the new-onset diabetes in that immediate, I just had the surgery, I just had all this stress, I just was bombed with all the steroids, now I got diabetes, so that perioperative period. And then there's those patients that get it chronically, so they gain weight from their steroids, their immunosuppressive agents start kicking in, so you have this chronic phase hyperglycemia patients that get it later. An interesting factor is the fact that we don't really understand who it is, but many patients experience apparent spontaneous remission once their immunosuppressants are at baseline. And we don't really know what exactly predicts for that to happen. But in most of these patients, it's almost, I like to think about it more like a gestational diabetes type situation. Once you had the diabetes presents itself in this period of time, it's likely that it could come back later, especially if they don't address lifestyle issues or the immunosuppressive medications are changed to those that can predispose them more strongly to diabetes. But many of these patients may go to complete remission and then have it come back 1 year later post-transplant. So depending on the organ transplanted, the rates are also different. So here's just some of the numbers. With the kidney, 20 to 50% after 12 months, liver 9 to 30%, heart 28 to 30%, lung 6 to 45%. And this is all based on different studies published for the different things. So there are risks. The risks for new onset diabetes are, of course, specific and non-specific to the concept of the transplant. The non-specific ones should be fairly obvious in some degree. Age, so higher the age, the more likely. The consensus is over 45. There was a nice study done on Medicare patients, Medicare transplant recipients, that showed a relative risk of new onset diabetes over the age of 60 of 2.6. And then obesity, of course, is a big one. And we all know about this. Analysis has actually shown there's a 1.4-fold higher risk of getting new onset diabetes post-transplant in patients with BMIs of 25 to 30. Above 30 is double the risk. And the relative risk is the second strongest. So age was the number one in that Medicare study. Age was number one, and number two was obesity. So if you read the joke, well, it seems your weight is perfect. You just happen to be 11 feet too short. So that's now race is a big one in terms of the African American population and the Hispanic population. And it comes with a caveat that African Americans tend to need higher levels of immunosuppressive medications like the tacrolimus, which we're going to talk about in a second, is so strongly linked to developing new onset diabetes as compared to other immunosuppressive agents. Asian Americans about 5%, whites about 4%, so definitely race is a big one. Family history of diabetes, history of gestational diabetes, and of course the impaired fasting glucose that I mentioned earlier, or the impaired glucose tolerance. If you can look at this table, on the very bottom of it, so if you can see the different numbers for the sugars, so less than 70, nobody got diabetes. But starting from then on, the higher your sugar fasting was, the more likely you were to get new onset diabetes after your transplant. And it went all the way to 80%. And we were talking impaired fasting sugar here. These people are not officially diabetics. This last range with the 80% on it is for people who had sugars fasting between 121 and 126. So you can see how much higher the risk of getting this is just from the impaired fasting glucoses. Immunosuppression. So now we're going to talk about specific to the transplant process in terms of risks of getting new onset diabetes, and immunosuppression is huge. So whether a patient has some kind of induction or not, if they don't have induction, they are more likely to get diabetes. If they use tacrolimus, they are more likely to get diabetes. And you can see the red, the lower the line goes, if you start out with no diabetes at all, so the lower the line goes, the more likely you are to have diabetes. And then if you keep going, you can see now steroid use. Of course, steroid use, the pink line is the lower line, will also have more diabetes in the context of immunosuppressive therapy. HLA mismatch, so they found links with that depending on what it may be. In thinking about it, I'm guessing that if you do have the HLA mismatch, this may correlate with immunosuppressive agents needing to be a little more aggressive, so it may all boil down to immunosuppression as well. If you are lucky enough to get the male donor, apparently that also is linked with, I don't know why. I guess male donors just happen to cause more diabetes than female donors. And then deceased donors versus live donors. Polycystic kidney disease has been shown to cause more diabetes after transplant as well. So that's where the type of underlying renal disease factor comes in. Now, here's an interesting one. If you're infected with hepatitis C, you are 4 times more likely to get diabetes after transplant. And this is actually considered to be something that can be corrected. So if you have a patient who has Hep C and is going to be getting a kidney transplant, if you can treat the Hep C before the transplant, you are going to decrease their chances by 4-fold of getting diabetes. And there's concrete studies that have shown this to be the case, that it does decrease the incidence of post-transplant diabetes if you treat the Hep C beforehand. Infection with CMV has also been shown to be linked. And of course, if you have high sugars in that perioperative period, you are, it's very likely that you will continue to have diabetes from then on. So you can classify the risk factors into those that, oh, well, you were born Hispanic, what can you do about that, you know? And then the ones where you can potentially modify, including the Hep C, and those that are definitely modifiable. In the modifiable category is the list of all the different immunosuppressants that we're going to talk about more in a second. And, of course, the obesity component and other metabolic factor components. If the patient's not exercising enough, if they're not eating right. These are all things that we can target and we should target in the pre-transplant period. So let's talk a little bit more about the medications. So you all know steroids. Definitely induce insulin resistance. I mean, everything you can imagine that would go wrong with diabetes goes wrong with a steroid. It induces insulin resistance, stimulates lipolysis, inhibits insulin release, so you're not releasing insulin, and now you're making more sugar because you stimulate glucagon release. So now you're making more sugar. The sugar doesn't really work that well, so it's just a perfect recipe for for diabetes. But the fact of the matter is that we've seen a lot less problems with the new onset diabetes after transplant, a lot less of the insulin, because now we're more aggressive about removing steroids than ever before in the past. So moderation in its use has been felt to be a really good thing for decreasing the diabetes. Another risk factor is using pulse doses. So if you can avoid that, that will help the blood sugars as well. Now the calcineurin inhibitors. These are the tacrolimus, the cyclosporins, and the key thing is that many studies have shown that tacrolimus versus the use of cyclosporin or sirolimus alone increases the risk of diabetes, new onset diabetes. And levels above 15 of the tacrolimus are the most strongly associated with impaired glucose tolerance of up to 15% and new onset diabetes of up to 32%. They both cause reversible toxicity to the islet cells, and I'll show you a picture in a second that shows that toxicity. Now, tacrolimus, what happens is that they cause swelling in the beta cells, and they cause release of the insulin from the vacuoles where it is accumulated. So it is felt that both these calcineurin, the tacrolimus and the cyclosporin, decrease the amount of insulin you make basally, so you're making less insulin to control your fasting sugars, your baseline sugars, and you decrease the amount of insulin you make in conjunction with food. You normally make a little more insulin when you eat. All that goes down. And then it's felt to maybe be related to the transcription factors that are associated with this, maybe decreasing the mitochondrial numbers. And here's a nice picture showing a nice normal beta cell on A. B is one that's been treated with cyclosporin. You can immediately see some vacuolization. The dark stain is to the insulin. Okay, so there's a lot more insulin in the healthy cell. You go all the way to C, that's a tacrolimus affected beta cell. It's basically depleted of insulin. So you definitely have issues. You can see how there are issues with the with these medications in the path level, looking at the slides. Sirolimus affects the second phase of T cell activation. It works somewhat similar to tacrolimus, but not exactly the same. It has been found to be diabetogenic, and it's felt to be something related with it affects the action of insulin and likely the islet cell function, but it's not as well defined as what we know about cyclosporin and tacrolimus onto why it causes these problems. But conversion from tacrolimus or cyclosporin to a sirolimus regimen has not been shown to help improve insulin resistance. And in fact, diabetes is also very prevalent in these patients with sirolimus. Azathioprine, mycophenolate, antithymocyte globulin, and OKG monoclonal antibodies. None of these have been shown to have diabetogenic effects. So these are okay in the terms of not causing this new onset diabetes. Touching base on other medicines, I know these are not immunosuppressants, but I thought it was a good place to mention that patients who are on statins, ACEs, and ARBs tend to be associated with lower risk of diabetes. And long-term use of Septra, and this is more so like something that's been associated in the long transplant patients, has also been associated with decreased risk. Now, there's different combinations that are worth considering and some that are not worth considering in terms of trying to figure out what's best for the patient. And there's higher incidence of new-onset diabetes with tacrolimus and azathioprine as compared to tacrolimus and cyclosporin or cyclosporin and mycophenolate. Tacrolimus and mycophenolate combos had lower incidence compared to either one, tacrolimus or cyclosporin combined with sirolimus. So if you combine sirolimus, the bottom line is you combine sirolimus with any of them, you're going to have a worse case result than if you combine it with a mycophenolate. I don't know if that makes more sense to everybody who deals with this a lot more than I do in my practice. So clinical impact. Diabetes is going to affect your patient's survival. They have increased mortality. There's going to be neuropsychiatric issues associated with the diagnosis and the treatment and the management of it, because it is tedious. 1 year survival is decreased by 83% compared to 98% in people who get diabetes. 5 year survival, 87% to 93%. So there is an actual numbers. There's the decreased mortality. There's increased mortality. They're more likely to get cardiovascular problems. So relative risk of 1.5 compared to 3. And if you can look at this chart in terms of patient survival, and this is follow-up in months post-transplant, a patient who develops new onset diabetes behaves the same as somebody who had diabetes coming into the transplant in terms of their overall survival. So just having diabetes develop in that post-transplant period already decreases your survival, like if you've had diabetes from before. It affects the allograft. So 12 years, the survival of the organ is going to be decreased. So a comparison of 48% versus 70% in those without and with the new onset diabetes. We wonder if this could be related to the cardiovascular mortality and the morbidity associated with the new onset diabetes. Could it be because of diabetic nephropathy in those kidney patients where we see this, that they're developing diabetic nephropathy in their transplanted kidneys, and that's why they don't do as well? Or is it because of the fact that we're messing with their immunosuppressive agents in the context of avoiding diabetes, more so in patients who develop diabetes? So the answers are not very clear of why this is, but it's obvious that it is happening. And it is important in this point in time to mention that acute rejection is the single most important determinant of graft survival, not the diabetes. And it needs to be more important to escalate the immunosuppressive therapy regardless of the new onset diabetes risk, because that's going to be the most important factor. And that's where people like myself come in and say, you guys do whatever you have to do with the immunosuppressants and I'll just increase the insulin. So, it's what needs to be done. There's definitely increased risk of infections, UTIs, pneumonias, and the infections tend to be more fatal. So it's not just the fact that they had more, they just are worse as well. And they can develop, of course, all the diabetic complications, usually at an accelerated rate. So the neuropathies, the nephropathies, the retinopathies, all those things are going to happen a little quicker than they would have if they had not had the transplant. And of course, now you're diabetic, you run the risk of having hyperosmolar complications, hypoglycemic complications, and possibly DKA in the right circumstance. So when we talk about managing this, we have to divide it into 3 different areas. So there's the before transplant. What are you going to do before you're transplanted to avoid this? In the after transplant period, immediately you just got your transplant, you got diabetes, and then in the post-transplant phase. And the pre-transplant phase is all about trying to identify those patients with risk factors. And you want to initiate lifestyle interventions immediately. So counseling in terms of dietitian, counseling for weight loss. If there is Hep C, you want to go ahead and treat it if possible. And of course, screening for cardiovascular risk factors is going to be big. So all those metabolic syndrome factors in terms of the cholesterol, in terms of the high blood pressure, you want to go ahead and screen for them and treat them. And you may want to consider, even though I really don't, I should have asked, but I don't know if it's practice here to do an oral glucose tolerance test before transplant. It's recommended. It's not strongly recommended because of the tedious factor associated with staying 2 hours sitting there just waiting to check your sugars again. But it is more so diagnostic than fasting. In many circumstances, you diagnose diabetes a lot earlier with an oral glucose tolerance test. So that could be something that could be easily added to a before transplant screening process that could find even those pre-diabetics more thoroughly. As we discussed earlier, there is just being impaired glucose, impaired fasting increases your risk of developing diabetes almost 2.5-fold. And now there's also all those patients who are waitlisted. And then they wait a year and 2 years, and they're waiting. So at which point in time do we say, okay, now we are going to continue following your fasting sugars. You develop diabetes or you develop impaired fasting sugars. Now we're going to send you to the dietitian. There probably should be some kind of follow-up in that context of the risk factors for new onset diabetes in those patients waiting that are waitlisted. In the peri-transplant period, you just got your transplant, your sugars are very high. You want to try to keep those blood sugars. I mean, you're usually going to be likely on an insulin drip, in pre-meal 140, random glucose is less than 180, and of course, decrease the insulin and hopefully wean it completely off by the time they're off the perioperative stress. If the patient is discharged from the hospital with normal blood sugars, they need to have fasting blood sugar checked weekly for the first month, then every month for 3 months, and then yearly thereafter. If impaired fasting glucose is detected at any time, you need to consider an oral glucose tolerance test because the oral glucose tolerance test may immediately diagnose the diabetes that may not be seen immediately in impaired fasting. If both of them are impaired, so impaired glucose tolerance, impaired fasting sugar, you need to refer them for lifestyle counseling. At that point in time, even in normal patients that are not transplant related, we usually don't start any medications, not even metformin. We just tell patients you need to lose weight, you need to follow the lifestyle interventions, and it's not until they become diabetic that we actually start medication. So that's the next step. You need to refer them to lifestyle counseling at that moment. Now, if the patient did have very high sugars in the perioperative period, you may want to discharge them too with instructions to check your sugars 4 times a day to make sure they don't have any problems. Now, of course, if they're discharged with diabetes, the treatments are going to vary because there's going to be those patients that are going to be diet controlled. There's going to be those patients that are going to need insulin. But they should all be discharged after getting self-management education. So that's just imperative in any patient who gets diagnosed with diabetes. I discussed already the weekly fasting sugars and things like that. But once they are out of the hospital, it's been 3 months, you can start using those A1Cs. If the A1C 3 months post-transplant, I mean, if they're greater than 6%, you want to start them checking their sugars at home. If it gets to be greater than 7%, that's when you really need to start medication in these patients. Now, that's in most patients, in like my clinic patients, and this is the instructions for like the transplant period type patients, but in most cases, we would probably consider starting something at 6.5%. Because usually the goal afterwards is going to be to try to keep them as close as possible to 6.5%, definitely less than 7% for the A1C. Now, you may want to consider changing the immunosuppressant therapy if they're impaired fasting sugar showing up and you're seeing that the diabetes is coming, and definitely continue aggressive management of cardiovascular factors. decrease the dose, and these things I know it's so obvious. I mean, decrease the dose of the steroids as much as possible, but not as obvious may be the fact that if you use divided doses of steroids, that can help a patient's diabetes. So if you know you want to put your patient on prednisone, instead of doing 20 milligrams once a day, why not do 10 milligrams twice a day? The spread out doses are going to even out the elevation in the blood sugars a little better and cause less of a high impact dose like would have in a morning dose. It just helps also with the management of the medications for the diabetes to have the effect of the glucocorticoid more spread out through the day. So even a 10 milligram dose 5-5 is probably going to be better than doing 10 milligrams once a day. Now, I know that this all has to balance with convenience and factors in terms of the patient being compliant with their medications and all the different things, but it is definitely something that can be of benefit, that is a very slight adjustment that can be done. With tacrolimus, I mean, every time you can reduce the dose, of course, please reduce the dose. A switch from tacrolimus to cyclosporin is not recommended necessarily. The bottom line is that we know that diabetics have problems with graft survival, but patients who take tacrolimus don't necessarily have graft survival issues. So for the sake of switching a therapy that's working for their graft at the moment just because they're developing diabetes is not very well grounded unless the patient is an extremely difficult to manage diabetic. That's the only circumstance that it might be a good consideration to switch them off tacrolimus. But I don't know if that makes sense. I mean, it's just the fact that tacrolimus we know will help the graft survive better. It would be nice if they didn't have diabetes, but if it takes a tacrolimus being on board, then it's so be it for that factor. It's not absolutely necessary to switch the medication for the sake of diabetes. And I mean, just to kind of illustrate the cyclosporin and tacrolimus issue here, this 0.0 here in the chart is the days before and after transplantation. The red line is the tacrolimus, the blue line is the cyclosporin. And it's interesting to see that even in the pre-transplant period, the cumulative incidence of diabetes is still kind of rising just from the chronic illness I'm guessing the patients are experiencing even before being transplanted. But you can see how quickly it goes up to a risk of about 30% with the tacrolimus compared to the cyclosporin. So there's definitely a reason. I can't vouch for. I don't take care of starting people on cyclosporin or tacrolimus in the post-transplant period. But I would presume that if it is an option, if you have a patient who already has a lot of risk factors for developing diabetes, that you may want to consider cyclosporin versus tacrolimus as a starting medication. Now you're diabetic. What do you do? So this is what we do with diabetics in general. We first tell them, go ahead, go exercise, try to bring your sugars down. You can do it, eat right. That doesn't work. We start some kind of oral monotherapy, then combination therapy, and finally insulin. I find this is the escalation of therapy in most people who become diabetic, but in these patients, many times they're coming already with very, very high sugars, and because of their respective transplant, the kidney or the liver, you may not want to use metformin. You may not want to use, so the different medications, it's going to be a little more different. So I find that many of these patients end up on insulin a lot quicker than what this chart would actually show, And, of course, aggressive lipid and blood pressure control like we've discussed. I know this is very packed, and actually you can't even see the half of it. But what I wanted to show you about this is it just has a list of all the different medications we're basically using to treat diabetes, except for insulins. And if you look at this here, you'll see that many a medication has GFR issues, creatinine issues. So those things need to be kept in mind when we're dealing with a patient who is in a frail moment, just post-transplant. Is the organ going to stick or not? Is the creatinine going to be the same today as it was? It's going to be 1 week from now. So this is just another angle. And then the last little piece here is that some of these medications have drug-to-drug interactions, and some of them actually are metabolized by the CYP3A4/5. Which basically means that they will affect the levels of your cyclosporins, of your tacrolimus, and those things need to be monitored. So Now, for the medical treatment of diabetes in general, post-transplant, I would not recommend the use of metformin or the Actos and Avandia drugs. Now, Actos and Avandia you probably wouldn't even think about, but clearly these medications, Actos and Avandia, can increase fluid retention. And in general, in your heart, in your liver, in your kidney, I mean, you don't want to have any of that. Metformin, for obvious reasons, with the creatinine being a possible fluctuating issue, with the need for contrasted studies, you really don't want to risk lactic acidosis as a complication. So those are out. So a medicine that is inexpensive and it can be considered is, of course, the sulfonylureas. Personally, I'm not a huge fan of sulfonylureas because of the potential of hypoglycemias associated with these medications, as well as the weight gain, because you have to eat to take them, and if you get a low sugar, what do? You eat more. So inevitably, it's going to lead to weight gain. If you are going to start a sulfonylurea, you need to consider the glipizide or the glimepiride. Never try, don't, for no reason, transplant, post-transplant, no transplant, no glyburide. Don't use, glyburide is a first-generation sulfonylurea. It has a longer half-life in your system, so the risk of hypoglycemia is much higher than with the glipizide and glimepiride, as well as it affects post-cardiac reconditioning. So if you get a heart attack, you may not feel it, which is not a good thing. So it's just not a nice medicine. So I would recommend against the use of glyburide. And I'm always switching patients off glyburide up, left and right all the time. Meglitinides, you don't see them very often. They are expensive. They work similarly to the sulfonylureas. It would be nice if we were not that expensive, because they're actually nicer in the sense that they act very quickly and they're out of your system quicker. So it's the Pranding and the Starlix, but it's what it is. So most of the time we just can't really get that medication. It's not a practical thing. There's an exciting new medication area here with the GLP-1 based therapies. And particularly the pill forms, the DPP-4 inhibitors. So we're talking the Januvia, the Onglyzas, the Tragentas. Now, these medications have been associated with effects in the CYP mechanism, but if that is considered and in you adjust things just right, these are medicines that can be used in patients who have perfect kidney function, as well as in patients who are on dialysis, as long as the dose is correct. Tragenta, for example, is a 5 milligram flat dose no matter where you are in that range. Januvia is 3 doses, 100, 50, 25, depending on where you are in that GFR range. So these medications help your pancreas make more insulin in the context of eating, so they're not going to induce hypoglycemias like the sulfonylureas do, and it also may enhance the GLP-1 effect that tells your brain, oh, you know what, you're full, don't eat anymore. So it can help you lose weight. So it's got like all these nice little perks. The GLP-1 based therapies did get a hit about 2-3 years ago when a study showed that they may be linked, maybe 2% of people who use them may have a higher incidence of pancreatitis. And that's just, if you see TV, you probably see the lawyer things. If you've had Januvia and pancreatitis. So it all comes from that one study. Now, it was a poor kind of incidence-based study looking in hindsight, and many studies, a few of the studies that have come back recently to enlighten us if this is true or not, have actually not shown the concern for pancreatitis as much. Personally, I prescribe these medicines a lot. I don't really see it, even though I warn all my patients about it. Like if they get epigastric pain, they race to the back, stop the medication right away. I haven't really had that happen. It would be great to consider the injectable versions of the medications, because just as good as the pill forms are, the DPP-4s, the injectable medications work just that little bit better. So you're basically the GLP-1 agonist, you're injecting the hormone itself, you had higher levels of GLP-1, and but the injectable versions do have a lot more strict guidelines in terms of GFRs. So it's something to consider, and I usually do so more so in that 1 year post-transplant. You already kind of reached your point immunosuppressant-wise, and you're needing to lose a little weight or something like that. These medications are not a bad idea. So just enlighten you about the GLP-1s. Now, if your A1C is consistently above 7 or your fasting sugars are greater than 200, you need insulin. There's no way around it. If you have metabolic decompensation, if you have adverse effects to the oral therapies, or you can't use the oral therapies at all, like I mentioned, the metformins, the sulfonylureas, different things for different reasons. At that point in time, you can consider referring them to somebody like me, or kind of having the primary care or somebody else kind of manage, because the insulin regimen can be tricky in these patients, because it's basically, you really want to try to treat them almost like a type 1 diabetic and give them the full round benefit of the insulin therapy that they should be getting. And when you're starting insulin, so the bottom line is that you need to target two different things, not just the basal rate, the basal level. So when we have normal working pancreases, our pancreases are always making some insulin all day long to keep our basal levels of sugars right, but we always make a little bit more insulin before we eat, which are those peaks. So you need some kind of insulin like the lactose, levemir, and pH to keep your sugars even keeled throughout the day, and then you need some kind of insulin to combat those the higher elevations of sugars that come with meals. So if you're going to start somebody on medication for the diabetes and you're going to start them on lactose, I would advise to consider starting a DPP-4 or a glipizide or something like that, in addition to target the mealtime doses if you're not going to start mealtime insulin doses right away. You really want to have something on board that's going to help with that angle of the treatment. And this is just like a little chart with the different insulins, so we don't need to dwell on that. This is just illustrating how the different formulations of insulin therapies are basically meant to target this physiologic range. So the mixed insulins on the right upper corner, how you try to target the breakfast and the dinner. Lunch gets a little bit sacrificed in those settings. So those are the 70-30s insulins. I just find this chart very, very interesting. So the best possible combination, you could always put the ultimate best treatment for diabetes, and I know it's probably not right English, but is having a basal and a prandial insulin in combination. You're going to have the most physiologic effect of possible in terms of managing. Make sure you check the sugar. So we check A1Cs every 3 months. Target around 6.5%, at least less than 7. Caution with using the A1C patients who are on EPO, who have anemia. So it's very important that this particular population keeps a log, because the A1Cs are not going to be 100% reliable. They're just not. So despite the use of the A1C commonly, keep a log as well, because that's going to verify whether the A1C is accurate or not. You need to start food care. They need to start checking their eyes once a year. They need to start following the neuropathic guidelines. You need to be so with that transplant patients, anything can change. Steroids can be added, can be taken off. So you have to be very flexible about it. And then in those acute rejection moments when the steroids are added in their full degree, doses of insulin can double. And you need to be very aware of when those steroids go down, because that's when those hypoglycemias happen. And many times the down is going to happen when they've already left the hospital and they're at home. So you want to give patients very clear instructions of how to reduce their insulin doses in that home time so that doesn't happen. So in conclusion, new-onset diabetes after transplant is a complication that has dire consequences that we should monitor for at all times in the pre-transplant period, in the post-transplant period. And there's things that we can do to help it. Just like there's things that we can't modify, there's things that we can modify. And once the person does have diabetes, we need to be very good about making sure that everything stays as close to normal as possible to prevent all those bad effects from coming. I guess one thing I didn't mention here is that one great thing we have here is this wealth of knowledge that we can tap into. A lot of the data that I presented to you today is based on American Diabetes Association guidelines and different things that are general for the rest of the population. But this is a very special population, and it would be great in the future to do simple studies to find out more so about the risk factors for this condition, look into what causes this, what can we do to prevent it a little better. Or maybe those patients that meet certain criteria, can we send them for the diabetic classes that Tampa General offers, even if they don't have diabetes yet, so that in that post-transplant period, they're already educated and they already know what a carb is and how to count carbs and how to eat right, how to exercise, so make it a mandatory thing for those patients who are higher risk. It's just a thought. So any questions? Pretty straightforward. Oh, thank you so much.